So this lecture today is going to be a very basic introduction to screening mammography. This lecture doesn't have a lot of images. The future lectures will basically, I'll do the first part will be a lecture, and the second part will be cases, because I like to kind of go around and let everybody practice. I think that's really the best way to learn. But this one will just be kind of a really basic introduction. So what we're going to do is talk about the concept of screening mammography, kind of the why, who, what, all of that. We're going to talk about the ACR guidelines. We're going to talk about the standard technique for a screening mammogram, and we'll also just briefly touch on normal breast anatomy. And then we're going to introduce the BI-RAD system, which is our reporting system in breast imaging, and we'll talk about how we interpret a screening mammogram. At the end, I'll have a couple of slides that just show basic screening with ultrasound and MRI, just to kind of show all of the modalities. So why is there a breast imaging section? The statistics for breast cancer, it is the most common cancer among American women when we exclude skin cancers. 1 in 8 women in the U.S. will develop an invasive breast cancer during their lifetime. And it's the second leading cause of cancer death in women. Lung is number 1, and the chance of dying from breast cancer is 1 out of 36. These are all from the American Cancer Society website. This is their statistics for 2016. About 246,000 cases of invasive breast cancer will be diagnosed. 61,000 cases of what we call carcinoma in situ, or it can be ductal or lobular, will be diagnosed, which are basically their cancer that is kind of contained either in the duct or the lobule. And 40,450 women will die from breast cancer in the United States this year. That's their estimates. So that's why we kind of care about screening for breast cancer. We have noticed that breast cancer rates decreased back in from 2002 to 2003, and that was when all the data came out supporting not taking hormone replacement therapy. So there was a drop at that point. Currently, there's more than 2.8 million breast cancer survivors in the United States. So what are we doing in a screening mammogram? Our goal as the radiologist is to detect, characterize, and evaluate findings that are suggestive of breast cancer. So we have to know what we're looking for to find a breast cancer. What we're doing are annual screening mammograms in women that are age appropriate and they're asymptomatic. And this screening mammogram is the only modality so far that's ever been proven to significantly reduce breast cancer mortality. So what are we talking about when we say a screening versus a diagnostic study? Screening, like I said before, it's an x-ray of the breast in an asymptomatic woman, so a woman who has no complaints, no issues. Diagnostic mammogram is an x-ray of the breast in a lady who has a sign or symptom, a mass or a complaint, or a patient who we've given a BI-RAD 0 on a screening mammogram and recalled for additional imaging because of something that we saw on the screening mammogram. So the ACR has guidelines. We'll talk about those first. I know there's a lot of confusion. The ACR still is recommending that annually we do screening mammography in women that are over 40 who are at average risk for breast cancer. They don't have an upper limit. Basically, if the lady is willing to undergo a biopsy and or surgery and can tolerate those things, then they say continue to screen. So we have ladies recently that are like 78, 80 years old who are diagnosed with breast cancer. And sometimes it'll be something obviously other than their breast cancer that's going to kill them eventually. So we'll talk about the special cases. These are all ACR guidelines, so they're online. You can find them. You don't have to memorize all of this special case stuff, but just to know that there are special cases. So there are patients with genetic syndromes or known mutations that we start at age 30. We don't start before age 25. There are women with first-degree relatives that have BRCA mutation. Maybe they don't know that they have it, but we can start yearly at age 30 for those ladies. And I put this 5 to 10%, so when we think about breast cancer, we have to realize that the majority of patients that are diagnosed do have no family history. There's no mom, daughter, sister, anybody, grandmother. It's just 5 to 10% of the breast cancers that are diagnosed that actually have a family history of breast cancer, so it is low. Any woman with a greater than 20% lifetime risk of breast cancer on a risk model, and I'll show you just a brief what we talk about with risk models. They start yearly at age 30. or 10 years earlier than the relative, the first degree relative that was diagnosed. So if their mom was diagnosed at 45, they'll start at 35 yearly screening mammogram. If they had mantle radiation, 10 to 30, then they'll start yearly 8 years after that radiation therapy. So basically, if they had mantle radiation as a child, a young adult, then they'll start 8 years after. But you never start before 25 is what the recommendation is. And a woman who's had a biopsy that showed a lobular neoplasia, any kind of atypia, especially atypical ductal hyperplasia, any DCIS, invasive cancer, or ovarian cancer, no matter what age they are, we actually start yearly after that for them. This is just to kind of show you one of the assessment models that the geneticist or the hem-onc doctors can use to try to guess, your risk for breast cancer. It doesn't tell you your definite risk. It compares a population of women in the same statistics, and it was actually based on Caucasian women, so they've tried to extrapolate it now to other women, and I think it's kind of an ongoing thing, but basically it's how much estrogen have you been, how many hormones have you been exposed to. So you think about things that increase hormone exposure. So when did they have their first menstrual cycle? When did their first child? Basically, if you had your first child after 30, that gives you a little bit of an increase. If it was before 30, then that's good for you, helpful for you. If you have a family history, how many biopsies have you had in the past? And you can put all these numbers in online. It's not something you have to memorize, but this is just something you can use to kind of help you judge people that are at a high risk for breast cancer. So what about the U.S. Preventative Services Task Force? Because this seems to be a common question, and it comes up a lot. So they are a group that is an independent panel of experts who meet and discuss guidelines and look at the literature and try to make the best recommendations that they can. And they came out with new guidelines in January of 2016. So the reason that they have new guidelines is because they say screening mammograms can trigger things that are unnecessary like biopsies, and they also can make the patient extremely anxious. They also say that we find cancers that would never cause a problem, and so we need to really be looking at how can we use our resources for the best possible outcomes. So based on those things, they're saying that we should only do mammograms every other year from 50 to 74. That's what they're supporting. And they're also saying starting before that should be something that you talk about with your physician and make a decision. And after 75, they're saying they don't really have any sufficient evidence to say one way or the other. From our standpoint in breast imaging, Dr. Laragi and ourselves have a problem with age 50 because we see a lot of breast cancers in ladies younger than 50. And we have a problem with every other year because we have many cases where a breast cancer shows up in 1 year and is kind of, wow, it's almost overwhelming. So it's like we find some issue with that, but I think they're looking at population data and trying to decide what can they do for money to help us, in healthcare, best spend our dollars. So that's what they're looking at. So what we're talking about with screening mammogram, like I said, asymptomatic patient, our goals in any kind of screening are obviously you want to be highly sensitive for the disease you're looking for, and this is supposedly the rate for breast cancer in a screening mammogram, somewhere between 84 and 98, depends on the reader obviously. You want to have a low false negative rate, and you can have a lower specificity. So the biggest thing for us is our callback rate. What we're on a screening mammogram, when we give a BI-RAD 0, that's considered a callback, and it should ideally be less than 10% for each radiologist. These are things that are monitored, and you should try to target to be less than 10% so that you're not calling back too many patients and causing unnecessary workup. So let's talk a little bit about the technique. On a screening mammogram, we basically get 4 x-rays. We get 2 images of each breast. One is the cranial caudal view, or CC, and we also get the MLO view, or the medial lateral oblique view. And that view is done because it includes the axillary tail and a little bit of the axilla. It's just the best view that we have to get all of that breast tissue in the image. The technologist you have is really important, and they can decide to do additional views just based off of the images, those 4 images. They can decide to do what's called exaggerated views, either way, medial or lateral, depending on if they don't feel like they included all of the breast tissue. They can also do an anterior compression view if they feel like the tissue behind the nipple's not well displayed on either view. So it's up to the technologist to add those views. This is what we're looking at. The bottom picture shows what just a general screening, just any mammography tower is going to look like. Obviously, we don't have a lot of radiation, so they just have this thin lead. The walls don't have to have lead in mammography. And this is what the breast is positioned like. For craniocaudal, it's talking about the angle of the beam. So you're going craniocaudal, they're put into compression, and they take that image, and then they reposition the x-ray tube, and then they take a medial lateral oblique view. So they'll do all 4 of those images, look at the images, and decide do they need to do more or not before they end the exam. And this is just an example of what you're going to see on your packs. You're going to get 2 views of each breast. So you're going to see your CC views. And what we're looking for is symmetry, obviously. So you're going to compare the breast. This is just a routine screening exam. And this is your MLO view. On your MLO view, you should see your pectoralis muscle. We like to see it down to at least the level of the nipple line. And you'll see axilla, so you'll get some lymph nodes in there. And so this is what we should see on just a routine screening exam. This is a very basic review of what the breast anatomy looks like. Obviously, we have ducts and lobules in the breast tissue and fat mostly. So this is a little bit better image. So on x-ray, just like on any x-ray, fat's going to be black. So any of the fat should be black. The breast tissue, the glandular tissue, is going to be white. And so when we talk about someone with dense breast, you can imagine it's completely white. It's very difficult to interpret because you just have all white, much less black. Obviously, most radiologists prefer to read images where there's a lot more black because it makes the contrast easier. And we should see the muscle, like I said, down to the level of the nipple on the MLO view. Sometimes we'll see the muscle on the CC view as well. But you'll have this area of tissue. And you can see here, maybe some of the tissue goes off of the edge, kind of tough to tell. But that technologist should have come in and done an exaggerated lateral view to include all of that tissue. Because sometimes cancers, upper outer quadrant's the most common area for breast cancer, and they can hide there. So if they don't include all that, you might be missing something. You can't just depend on one view to have seen it. So this is what we're looking at when we're looking at image quality. You have to make sure all of the tissue's imaged, and that's really the technologist's job. They need to make sure they include everything. All of this is included now without any issue because everything's digital. We don't have any screen film here, but if you do go somewhere where they have screen film, those are things that should be on each image, and they're on our images. You shouldn't see motion artifact or blurring on the image, no skin folds, and the images should be symmetric, so you should be able to compare them and say this looks the same on both. For a CC view, again, the tissue has to be included. The nipple should be in profile in the middle of the image. And we'll talk about this posterior nipple line, but it should be within 1 centimeter in size to the posterior nipple line on the MLO view, and the images should be symmetric. And these were some questions I think they had for the MOC exam recently. Some of those types of things that you think, oh, that's kind of silly, but they include that kind of thing on the breast part. So that's just stuff that's useful to know for the boards and technique-wise useful to know. So they say that the pectoralis muscle should be seen in at least 20% of the CC views. Even with your best technologist, best positioning, you're only going to see it in 30 to 40%. So if you're at 20%, then you're doing okay. You're doing a good job. And then if the muscle's not visible, you draw that posterior nipple line from the nipple to the edge of the margin of the film, basically straight back. And again, this is actually the question that I've seen recently. They wanted to know about this length of the posterior nipple line on the CC view. It should not be more than 1 centimeter shorter than the length of the same line on the MLO view. Let's talk about the MLO view, and then I'll show you the image so you can see where that posterior nipple line is, just so you have a picture. So like I said, we want to see the muscle down to the nipple. We should see the inframammary fold. The nipple needs to be in profile. Again, same thing with the posterior nipple line, that's important, and the images need to be symmetric. So this is just kind of more of the same thing, but we should see that, we should see the muscle down to the level of the nipple in 80% or more cases. So if your images don't have that, you need to talk to your technologist and tell them we need to work on something, because it's up to you to decide if the technique's appropriate. So if they don't include the muscle as much as they should, that's really up to you. In the MLO view, I think all the new residents need to go watch the mammograms done when they're on the rotation, because they can change the angle of the tube, and it really depends on the tube angle for each patient as to how they're going to get the best MLO view. So I encourage everybody to go see what the technologists do. This is our posterior nipple line, so you start at the nipple, draw back all the way to the edge of the film if there's no or edge of the image. We don't have film, but all the way back if there's no muscle. And then you do the same thing on the MLO, all the way back here. You draw a line that's pretty much just perpendicular here and go all the way back. And they should be within a centimeter. So this one is pretty close, 17 and 18, pretty close. So that's okay. So what are our limitations? We have mammographically occult breast cancer, so 5 to 15% of them cannot be detected by mammo. Just because you have a negative workup on a mammo does not mean that if they're clinically suspicious, they shouldn't do a biopsy. So you have to mention that in your report, that if you're doing a diagnostic study, if the clinician is worried about something that's palpable but you don't see anything on imaging, they still they need to send them to a surgeon and let the surgeon decide should they do a biopsy, because there are cancers that cannot be seen on any of our modalities well, and there should still be more workup done. So what are our false negatives? This is a big one. Dense tissue, overlying tissue. Because you only have 2 views on a 2D mammogram, you can have errors in just having dense tissue, so you can't see the cancer. Poor technique can be an issue if your technologist doesn't include all the breast tissue. Occult cancers, lobular cancers can be very tricky because they can present as just an asymmetry on a mammogram, not necessarily a mass. And then there's just days where everybody has an error interpretation and you just miss something, and that can happen. This is less of an issue now that we have 3D mammography, because dense tissue you can scroll through. Still, dense tissue is difficult, but overlying tissue is a little bit less of an issue with 3D mammography because you can scroll through the tissue and actually see through the breast tissue better. I'm going to do a physics lecture in breast, but this is just to kind of give you a basic idea of the radiation dose. What they say, the average glandular dose should not exceed 3 milligray for a single view on a phantom image. And the typical patient dose is about 2 per view. They say the 4 views, it should be an effective dose of about 0.7 millisievert. And the background average, this is just to give a reference, because those of you who haven't started physics yet, all this is like, what are you talking about? So just for us to know, in the US, it's about 3 millisieverts per year, just if you're walking around doing your day-to-day stuff. So this is all stuff that'll be relevant when we do more physics. So just kind of a little bit of information about that. Okay, let's talk about report creation. So we use BIRADS, which is the Breast Imaging Reporting and Data System. We're with the 5th edition, 2013 when it came out. We have a copy, and there's a little short version of it too. So this is probably one of the more important things to know for testing purposes and just for practice in general. You use it for all imaging modalities in breast, so we use it for mammo, ultrasound, and MRI. So this is the numbers. Basically, you have 0 to 6. 0 is additional imaging is recommended. 1 is it's a negative study. 2, benign finding. 3, probably benign, which is a whole category to itself. We'll have a separate talk on that. 4 is a suspicious finding. 5 is something that you basically are saying is going to come, needs to go to surgery and be taken out no matter what the biopsy shows. So you think this is a cancer no matter what, a speculated mass, that you're like, that is a cancer. And you're right, your thought there is greater than 95% chance that it's going to be cancer. And 6 is somebody who has a known breast cancer malignancy. So they'd have a known diagnosis already. So when we're talking about a screening exam, the only numbers you can ever use on a screening are 0, 1, or 2. The rest of these are not even pertinent on this talk. So if you're reading a bunch of screening exams, you're either giving them a 1, which is a negative, a 2, which is a benign finding, or a 0, which is you want them to come back and have some more imaging done. You see something that you don't know, you're worried about, you're concerned about, you mark it, and they come back for a diagnostic study. So that's all you're ever going to use on a screening. These numbers don't even apply, ever, on a screening. Just don't use them. So again, 1's negative. Now, in breast imaging, there can be findings that you see but you don't describe, and that's perfectly fine. You give those a 1. If you don't want to talk about vascular calcifications in somebody who's 70, you don't have to. Just give it a 1, you're done. Move on. You can describe them, however, if you want to. And if you do, you have to give that a 2 because you're describing it, you are saying it's benign, and you give it a 2. So if you talk about vascular calcification or a radiopaque biopsy marker or axillary surgical clips or whatever there are, then you give it a 2 because you describe something. But we don't have to. You don't have to describe those things. And then a 0, again, is if they're going to come back for a diagnostic mammogram and you're going to get possibly an ultrasound as well. So what do we do after that? We're going to talk about breast density. That's seems to be a big topic. You're going to say either it's almost completely fat or replaced, which is 0 to 25% fibroglandular. scattered tissue, which is 25 to 50, heterogeneously dense, which is 50 to 75, and extremely dense, which is greater than 75. And these last two are going to include a little statement that says basically we could miss a cancer in you. I mean, it pretty much says like we have cancers that are not picked up in people with these breast densities, especially on a 2D image because of the whiteness. So this is really, you're looking at the white tissue and how much tissue there is compared to fat. And it's very obviously subjective. So one radiologist may give it, scattered, one may say heterogeneously dense. It's really subjective. So it's not my favorite topic in breast imaging. But this is just a picture to show you what each one will look like. So obviously as you go up to extremely dense, you're going to get more white tissue, and it's going to be harder to see anything in the breast on just 2 images. It's very challenging. These patients, you may offer a screening ultrasound. So what else are we looking for when we're looking at images? We're going to compare to the priors always in breast imaging. You really have to have prior studies. And multiple years of priors is better than just last year because cancers can be slow growing. So several years. We're looking for symmetry. And what are we looking for malignancy? Because that's obviously our biggest thing. We're looking for a mass, a new mass, or any mass, any kind of calcifications that are new or developing. And we look for architectural distortion, and we look for asymmetries, which means the one side of the breast, is not symmetric to the other. Something's different. The tissue looks different. And this is just what our report would have. We always have the history. We list our comparisons just the same as anything else. The biggest thing you do is, the first thing you do is you're going to always have a breast composition on a screening mammogram. If you have a finding, you always have a description of where it is so that a next radiologist can come, because you have to assume somebody else is looking at the diagnostic. They have to know where you found a finding. So you mark it and you describe it. And then you give an overall impression. Every mammogram has to have a BIRADS at the end. So that's the biggest thing. Give a 0, 1, or 2 and sign it, move on, or save it, move on. So this is just helping talk about localizing findings. We're going to do some more because Simon was telling me that there were some things on like CC and MLO and trying to localize things a little bit. That's kind of important. So we'll do that in the diagnostic talk, and then we'll practice that too. But this is how we talk about the breast. So we talk about it in quadrants. There's an upper outer, a lower outer, upper inner, and lower inner. And there's obviously 4 quadrants in each breast. And you can divide the mammogram the same way. The upper breast, obviously on the MLO, is going to be here. The lower breast is going to be down here. The outer breast is positioned here. The inner breast is positioned here. So you can compare the two that way. You can also talk about it in a clock face, and so it's a little bit confusing when you first start out because it's clock face like you're looking at the patient. So you can go obviously 12 all the way around the clock, and sometimes that's helpful for people. It just kind of depends what you prefer. Either one of those is okay, but in your report you need to use one or the other. And then you also need to talk about description of where in relation to the nipple the finding is, how far, and measure it, and make a mark. Just a little bit about computer-aided detection. We use it on every one of our images, but it was approved back in 1998. And I like to mention it to the residents that I don't use it as my primary tool. I use it if I'm looking at my image and I'm worried about something, and I want to just see what did CAD think about it. And if it marks it, it gives you a little bit more certainty that, I should call that back. If it doesn't mark it, it doesn't help me in any way because I'm still going to call it back if I'm worried. So that's the issue with CAD. It's not going to mark everything. It misses cancers. It's a computer system, So just because it's not there doesn't mean you're not going to call something back ever. I mean, that's not going to change your opinion that way. And it's all your determination. You're the radiologist, so you have to decide, do I want to call something back based on that CAD? But with our system, you push a button, the CAD markings will come on, and it'll kind of circle a lot of things. And really it overcalls, so things that are not useful. So like this is an example. When you put the CAD markings on, you see all these little things that are marked, and you can take a better look at it and see if there's something. Each of these little things will mean something different just depending on which CAD you use, which system you're on. Some of them will mean calcs, some of them mean densities. It just depends on your system. This is actually just a marker for a skin finding, so that's to tell you don't worry about this little mass. That's on the skin. It's not actually in the breast. And this is actually a marker for a scar marker that way if something's underlying that, they had a surgery there. So not to be concerned. One of the other things that I kind of briefly wanted to mention, and Squares actually texted me yesterday about MQSA because he was trying to figure out, what do I need to do. Residents don't really have any issue when you do your fellowship. You're still considered in training, so there's not an issue about reading mammography when you come out. But there's a lot of, this MQSA is enforced throughout the country, so mammography is obviously highly regulated. They have annual visits. There are requirements for us, the technologists, medical physicists come in, and we have to have log books. All of this is kept, the techs do all of their QC stuff daily. Everything has to be kept up with very stringently. And there's a long list of stuff for physicians. But for the residents, you'll have all this. Basically, it's 60 hours of medical education in mammography. This is the biggest thing for you guys. You have to have read at least 240 screening mammograms under another physician in a 6-month period during your last 2 years. So it just has to be within 6 months. That's very easy to do here. We do a lot of mammograms, so you will have no issue. And when you finish and you do a fellowship, that number will still count from residency. So you don't have to worry about in fellowship, oh, I didn't do any more studies. That's okay. The biggest thing is that you get enough numbers when you're in residency. And then there's all these other things about what happens if you lapse or you don't, say you did a fellowship and then you didn't read breast for a couple of years. You may have to go back and actually read studies under someone for that 6 months again. So it's a big law. You have to just flip through, and you won't have to worry about it if you go right out and read them, but if you wait some time to read mammo and then somebody asks you, hey, can you start reading mammo or whatever, you may have to actually go back and redo some of the stuff. And then you're required to have also CME. So if you read mammo, you're required to continually do CME and mammo. It's very stringent, like I said, so you just have to kind of keep up with that. Real brief at the end, we'll talk about this just because it seems to be a kind of interesting topic. Probably not really relevant for the boards, but MRI screening in high-risk women, there are women that will get a mammogram and an MRI every year. These are women that have a breast cancer risk of about 20 to 25% or greater. And these are models, like I showed you that model, the geneticist or the hemonc doctor will do that model and say, hey, this person has a high risk. We want them to get screened with MRI. They may alternate out mammo and MRI. And there's these other things. If they have the BRCA1 or 2 mutations, we actually have some people here with the Lee-Fraumeni syndrome, and it's really horrible. But anyways, they will also probably go for MRI because of their increased chance of breast cancer. Ultrasound screening is not really done. I mean, it's not required or anything, but for us, if the tissue is really dense or the woman's under 40, we generally start with an ultrasound, and you'll survey each breast. The problem with ultrasound is obviously that it's up to the tech or you, whoever's doing the exam. It's very operator dependent, and you can easily miss things. So, that's a problem. If you don't do breast ultrasound all the time, you can miss things. So it's not as objective as a mammogram or an MRI. The other thing to mention about MRI is that it's going to pick up so much things. So you might have women that it may have an increased risk of breast cancer, and they get MRIs, and it's going to pick up all sorts of stuff. So you have to kind of explain that to them that, hey, you may go under unnecessary biopsies and things because you're getting MRI, because it can pick up things a little bit. It's obviously going to be very sensitive. And then they also need to have a mammogram because that's, like I said, the only modality that's ever been proven for survival. So they can't just do MRI. This is just an example of our normal anatomy on ultrasound. Here we do all of our own ultrasound, so you'll see the skin, and a lot of times we'll have a palpable area that's actually within the skin. We'll have a fat layer. We'll have the breast tissue, which is white, kind of mixed in with some, obviously some, more low echogenicity area, and then we'll have this retromammary layer. We'll see the ribs, we'll see the pectoralis muscle, and we'll see lung, obviously, posterior. This is just more normal anatomy, kind of showing an area or a mass and where it is in location of things. We see a lot of skin findings in breast imaging that somebody comes with something palpable and it just happens to be within the skin, so you get pretty good with that. Same thing with MRI, just kind of showing a different picture. What we're going to see, you're going to do axial and sagittal images, and you do one coronal image, but mostly those are our 2 planes we're going to use. And the crazy thing about MRI for breast is you're going to start looking at the images with contrast first. The subtraction images and the contrast images are actually the more important images than the others. You'll go back and look at everything, of course, but you start looking at what the contrast looks like first in breast imaging and go back and see everything else. So in summary, Screening mammogram is important. You're going to perform them on all women over 40 based on what the ACR says currently. We use BI-RADS, which we're going to talk about a lot this year, and it's very important for anybody in breast or reading any kind of breast imaging to know about BI-RADS in the lexicon. It's a very detailed, structured format, so it's a little bit different than just general radiology practice.